It's my tremendous pleasure to welcome Professor Michael Tong, who is the Chairman and Professor of the Department of Otorhinolaryngology, Head and Neck Surgery of the Chinese University of Hong Kong, to the Hong Kong Children's Hospital. Today we're going to talk about pediatric cochlear implants, and Michael has named it bionic ears, and I totally agree with that terminology, and Michael will tell us more about it. But perhaps, Michael, to begin with, you may wish to share with us your interesting journey in cochlear implant surgery.
Thank you very much, Victor, and thank you for the organizers. The story is actually of a bionic ear. Many of us as a child remember we have watched the very famous TV series, $6 Million Man. So he has got a bionic ear. So his ear actually is far better than human ear. So to date, after so many years of research and improvement in engineering, I'm not saying that we reached that level, but we are not that far away from the level of sort of like having a superhuman with bionic ears, or even normal human beings can consider an implant. Not far from now, I must say. But behind that, there are many, many stories, I must say.
Sure.
So I'm part of the story. So I'm also an observer of story. I'm creating some of the stories.
Right.
But I think it's more important to share with everybody those stories and to get across messages behind the stories. And I hope through this talk you understand a little bit about how the bionic ears work, what is it, and what are the important factors affecting its success.
That's wonderful, Michael.
Yes. Victor, do you know what is a bionic ear then, a cochlear implant? Have you seen one?
I know something about cochlear implant, but not to the level that you do.
Not necessarily. I'm bringing a small implant today. So this is an implant that we use today. So one of the models, there are a few models.
Yes.
So if you look at it, it's not a big device. So we could have a little zoom into the device over here. So you can see that this is the implantable component. So we place this component into the human skull. So I also bring along with a small human skull. So this is the temporal bone. So we place it on the skull. Okay. So and then we make a small opening. You'll see some of the surgery and surgical aspect later on when I'm showing you the stories. But the device itself will need to connect to outside. So you can see my patients are wearing something like a small box or carrying a very small box. So this is actually a very fast-speed real-time computer that allows sounds to be converted into electrical energy. So there are a lot of science and engineering behind it.
So
but
Michael, at the end of this little tail here, there are many electrodes.
Yes.
Is that right? So these electrodes go inside the cochlea.
The cochlea.
Is that right? You insert it all the way.
So in fact, Victor is right. Cochlear implant is the first device that are implanting into part of the neurological system of humans. So that was like 70 years ago, people began to do cochlear implant and implant into human ears and creating the sense of sound. Over the years, we don't know who are the patients who require those, because in the beginning, the sound that are created are very artificial and they're minimal information. So gradually over time, we see the improvement of these devices and the improvement of what we call the speech processing strategies. So nowadays we would do cochlear implant on children who are born bilaterally deaf, and later on you will see the numbers is growing because of what we call an expanded indications for cochlear implant. So we can touch a little bit on how these indications are expanded. And but many children, or most of the implantees, apart from the adults, we're not talking about adults today, are actually like one of my patients, Kyle. So I must say Kyle is, you look like he's a very cute little boy. When I first saw him, this is his mom on the left side. You see, mom smile, try to smile, but this is before the surgery. And you see a very different mom after the surgery. So this is the date after the surgery. Of course, Kyle doesn't have an a nice appearance. I did the surgery in 2016, bilaterally implanted at the age of 9 months, which is like the youngest limit at that time we're doing. So the youngest children we're doing probably is 6 months.
Wow.
Now we can
that's
do.
very good.
So,
yeah.
But 9 months, most people think, oh, is it really too young? You see the story, okay? I give you the story.
Triumph over adversity is the fairest competition in life.
Sound.
No matter who you are or how successful you may be, it's a skill that has to be mastered. As parents, we are always there for our children. Even before he was born, he was real to me. I talked to him every single day, telling him my thoughts, my hopes, and my dreams. I always knew I'd have to teach him a lot of things. But in reality, it's been my son who's been teaching me my greatest life lesson ever since the day he was born. From my successes as a professional athlete until my second career as an MC, I've been very fortunate and everything has worked out very well. But with the birth of Kyle, I received my life's greatest gift, but also my greatest challenge. When Kyle was 2 months old, the hearing test confirmed that he was profoundly deaf in both ears. It broke my heart knowing that he had never heard my voice, nor heard me tell him how much I loved him. I understood that giving up was never an option. Amidst my sadness, I knew I had to stay positive and not drown in any negative thoughts. My child needed me to stay strong. I knew I had to focus on the future and just keep pushing forward. The joy of seeing Kyle laugh and smile was the only thing that kept me swimming on.
Red.
You want the red one? All right. What are you doing?
I'm making the snake.
Despite a slightly later start in life, today, 1.5 years after a successful cochlear implant operation, Kyle's hearing and development are more advanced than the average hearing child his own age, and we are so incredibly proud of him. To me, seeing my son smile is my powerful backing.
Wow,
So,
Michael, that looks very nice.
Yes.
I noticed that the external processor is so small now. It almost looks nice. I suppose it comes in different colors as well.
Yes, you can choose the color. The bionic ear actually has evolved a lot. So cochlear implant is more receptive towards the outside appearance of it. But I must rewind the story back a little bit. Okay. Victor, how long do I know you? 30
Almost
years?
30 years, yeah.
So I rewind back. So this is a picture we took because because of COVID.
Oh my God.
I have plenty of time in digging into old pictures, and I also start to learn Photoshop. So I recolor it a little bit so it looks.
That was how we started.
Exactly. This is 1993. So why are we going for a barbecue? It's because I'm getting married. So you can see the young Victor. I'm also very young at that time. We have Dr. John Wu over here. He was the past president of the college.
Yes.
And I also have Virgil Yu. Dr. Virgil Yu is my buddy for the cochlear implant team.
Yes.
So we started 1993. Yes. So 93 is the year that happens to me. There's a lot of things that are happening this year. So I remember before 93, I just heard about cochlear implant, but never sort of like really think about doing it. I was basically a head and neck surgeon at that time.
Yes.
So if you
Yes,
remember,
I remember.
Victor, remember, I did a lot of head and neck surgery. So
yes.
and Victor is very concentrating on his pediatric at that time. So no one is interested in doing otology because it's a boring subject. I did a bit on what we call chronic ears because these patients have long-term ear discharge, and we have this story with teachings from very old traditional otologists, and said our clinic is very easy. It's filled up with loads of patients who have ear discharge. And we just have to clean them up, and we have a very happy day to end up with.
Yeah, and it became a very tedious clinic after a while.
Yes. So I can clean up 40 years on a section fairly quickly. But then I was asked actually by a startup company. So this is actually really a very early startup company with an audiologist who's a professional from Australia. Yeah. And she came to me and told me, have you heard about cochlear implant? I said, of course, yes. Do you know what it is? So he encouraged me to study more. So in 93, I flew all the way to Melbourne and Sydney. So actually with my new wife at the time. And then with Terence and Dillis, two of our best young people in the team, to learn what exactly is cochlear implant. So this is a very young startup company without funding. So the government is giving the research institute some funding, and they persuade us to actually think about doing this surgery in Hong Kong and start in Hong Kong. So really Hong Kong is one of the first place outside Australia that they want to start it as a title research, quote, a new venture places. So we start the surgery in 93, 94, and this is the cochlear implant team that we have created. So we know from the beginning that we need a team approach. And 93, 94, we are in the beginning of the hospital authority. So we can tell and share a little bit about how hospital authority come into presence at that time, how it influenced our funding. But let's watch a video, a very old video. ATV is still existing today.
區嘅前路㗎，嗱，來好彩咧，社會上面咧好多有心人士咧都好樂意去幫助呢啲咧身體有缺陷嘅小生命㗎。咁就好似今日咁喺中文大學咧就帶嚟咗一個咧為失聰人士一個好消息㗎，咁帶大家去睇睇啊。啊、E、U。
啊、E、U 對我哋嚟講只係幾個普通嘅發音，但係對一班失聰者嚟講咧，可以聽到呢幾個音作出反應嘅話咧，就係天方夜譚啦。
不過失聰救星人工內耳，令一切起死回生。94年底，香港中文大學響威爾斯親王醫院展開耳蝸內植計劃，利用手術將人工內耳放入失聰者嘅內耳，令佢哋恢復聽覺。
目前受惠嘅人已經有10位，4歲嘅泳琪咧就係其中之一啦，可以聽到嘢，心情用2個字可以形容嘅。
開心。
泳琪係天生失聰，屋企人響佢2歲嗰陣時至發現佢有問題，咁之後爸爸唐生就特登去羅省參加課程，學習點照顧個女同埋點同佢溝通。
8個月前啊，佢知道香港有人工內耳手術做啊，就即刻幫泳琪安排一切。嗱，手術順利，唐生對愛女之情咧就總算冇白費㗎。
食朱古力飲可樂好唔好啊？
好啊。
好啦，兩樣，因為佢夾埋一齊嚟做㗎。今日去游水好唔好啊？
好啊。
去游水踢波咧？
好啊。
踢波都好啊。着裙踢波啱唔啱啊？唔啱咪着裙踢波唔啱。着褲啊。着褲係啊，着褲。
泳琪聽到嘢可以講到嘢，唯一要避忌嘅咧就係要小心保護人工內耳啦。嗱，沖涼、瞓覺、做運動嗰陣啊，泳琪都要除低呢一副電子裝置㗎噃。
咁自從做咗手術之後咧，有咩改變咗咧？
開心咗啦，同埋喺同人嘅溝通容易咗啦，嚇，同埋佢要求多咗啦。
有咩要求啊？
要求去玩啊，食嘢啊。去街啊咁樣，即係比較多咗咯。手術之前咧，佢根本你唔敢奢望佢唱歌，但係手術之後佢梗係唱到歌。
另一位接受過手術嘅楊先生，當年因為耳膜發炎啊，導致失聰10年嘅。嗱，手術成功，亦令到佢重新聽翻嘢噃。
咁其實手術之後，病人仲要接受1連串嘅訓練，慢慢學習聽同埋講。好似2月照接受過手術嘅海欣，而家每個星期都要翻醫院做聽力測驗。
效果當然係滿意啦，同佢以前直情聽唔到聲嚟計，同埋戴嗰啲耳籠機嚟計，都根本都幫佢唔到。
咁佢即係識聽嘢之後咧，最多講係咩嘢咧？
拜拜。
拜拜。
為咗令更多失聰人士受惠，今日明德醫院呢就將一張10萬蚊嘅支票轉交俾威爾斯親王醫院，資助耳蝸內植計劃㗎。咁以後啊，將會有更多人可以聽到世界上美妙嘅聲音啦。
呢一種人工內耳嘅手術咧，的確為失聰人士帶嚟一個大。
So,
wow,
Victor, this
so gratifying.
We started off without much funding, and the Department of Surgery of the university granted us $1 million.
Yeah.
We've got funding from other charities at that time to start the program because it's very expensive to buy a cochlear implant. Today, it's still expensive, but comparing with say 27 years ago. We need to spend about $200,000 for an implant, which is a very expensive device. And it's not easy to find support for money.
Was it difficult to get the government to trust this procedure at its formative stage and funded. Like what they are doing now.
Yes. I must say in the beginning it's not easy. Everybody's like us, even professional, we don't know what it is. We don't know what we can do and achieve. And to sort of decision makers, it's also very difficult decisions. So, but I must say we're very lucky. So we eventually, Hong Kong has the first child in Asia. Hong Kong has the first example of its success of adults and children. So after about 3 years, we begin to have government funding. And we are also the first Asian sort of like locality with government funding. So this is thanks to the very young hospital authority, thanks to the team who are very energetic. Thanks into the 1990s, we are at a very liberal environment. Victor, you remember the days when you come back?
It was so impressive, your patients, they were doing so well. They were hearing and talking, particularly children. So impressive, even with those really early devices compared to what we have now.
Yes. So of course, this is a team's work, and we have many, many people behind the teams. You'll see many of them later on in my talk. But I also want to show you another story, which is Bingyu. So you can see Bingyu is a child in China. So she was born 1993. Victor, remember Nanjing?
I remember Nanjing.
Remember Nanjing very well. So we were in Nanjing. Remember, we tried to cross a road with the bicycles in 1994. And we spent about 15 minutes.
It was impossible.
Victor was asking me.
I didn't cross. Someone had to fetch
Shall
me.
we get a taxi to cross the street? So in fact, we eventually crossed the street because we finally blindfolded ourselves and just walked across and crossed the street successfully. But Bingyu's mother just found her speechless at age of 2. So this is typical of somebody who has no what we call a neonatal hearing screening program or pediatric screening program. So parents will only find a child to be deaf around age 2 or 3 because they just find out that they don't speak well. And her mom is not very well educated, but she is a sales lady in a department store. So just brought the child to the largest hospital and find this guy on the right lower corner. He's Professor Bu. Okay, so my friend, starting in the early 90s, but he's the only audiologist and audiology professor in a population of 80 million. So on the guy on the right upper corner actually came from Shanghai, and he spent his sabbatical in Australia in a Bionic Institute and subsequently joined the new startup company and become part of the company. So Bingyu in 1997, so we'll see how she performed at home.
张冰玉，张冰玉，小讲文明，张冰讲文明。
So a typical child, no response to sound, uninterested in the surrounding environment. So Victor, you think they are very different?
Well, exactly the same, except that we implant them. We ate them much earlier now.
Yes.
Yeah.
So, but this is just a very, very focus of a big problem.
Sure.
That we Chinese are facing. So how many deaf people are there in China, you guess? Altogether, like
30,000.
In fact, a lot more. So the next slide will show. So in fact, there are about say 60 million or over 60 million disabled people in China. 30% of them are deafness. So deafness is actually the largest, the most prevalent disability out of all disability. So out of those, about 12 million have deafness alone. Okay, so every year there are about 800,000 newborn who are born with some kind of deafness.
Yes.
So it's a huge problem. So In Hong Kong, as I told you, we started very early. China tried to use that because people know that electrical stimulation can give rise to sound. So first generation of what we call single channel devices are not quite useful, and the early electronics have problems because they're all explanted after some time. They get rejection, they get infection. So 95 is the year that we start to have hospital authority funding, and this is the year we begin to start multi-channel cochlear implant in China. So I am fortunate. You remember 95, 96, I was always busy. Yes. So weekend you don't see me anymore along. So I was flying all over China and Asia as well, because we started many programs in Asia alongside. So, and 95, 96, I also know Bill because I joined UCH at that time and become the chief in UCH. And I'm very fortunate because we have very good liberal hospital authority to help me to achieve. Yes. So I first met Bing Yu in 1997. So, so
how many channels did they have, these devices, in 1997?
In 97, the device that we're using have 22 channels. 22. So the device that we're using still have similar number of channels. Yeah. So we don't have the details on channels, but if we could use some speech processing strategy, we could increase the channels. Yes. Almost to a large number of channels, or infinite number of channels. So the slide just show that I was going around different places, cities. Eventually, I saw Bing Yu and I operated on her. So she was the first child being operated in the 6 provinces in Shanghai, the area.
然而，在冰玉手术1个月之后，陈慧才意识到，她帮助女儿回到有声世界的艰辛之路才刚刚开始。
Must be so amazing to her when she started to hear sound.
有了听力的小冰玉，
and Mum's
反而
voice.
不知道该怎么说话了。
So the surgery in 1997 and the year 2000 actually hasn't got much change, because we're also the first center, probably in the whole world, using the small incisions. So you can see that 2007, 2017, we haven't changed much in the surgery. So basically you need to open up the back of the ear. You need to make an opening. So this is called a mastectomy opening.
Yes.
And then with a child usually have a normal anatomy, we get into a channel. We call this a posterior tympanotomy channel. So the facial nerve actually is very close to the posterior tympanotomy channel. So in the beginning, the worries about parents is that are we causing facial nerve palsy? Because in China, you can see that the complications of facial nerve palsy has happened in a lot of people who have ear surgery.
Yeah.
And this is a worry about it, not just the cause of the implant. So Bing Yu's implant actually has another story, because she's the first child. They give her a 50% discount, and which is still a big amount of money to anybody in China in 1997. And she gathered everybody in the department store for a donation drive, and then also a community-based donation drive. The family actually sold their house. Okay, so they become homeless afterwards and rent the house afterwards.
Oh dear.
Yes.
Yeah.
So and eventually have the surgery. You see that this sort of investment are not uncommon. So what are the problems that we people running CI programs, we know the problems of the parents are actually, Victor, with the financial implications, especially if no government support.
But it has been very good. They should be able to get it free, and there are now 3 centers in Hong Kong. Of course, Prince
we have solved out Hong Kong's problem.
QEH and also QM, all doing wonderful surgery.
So my thinking is a little bit sort of like simple at the time being. So I think Hong Kong's problem is basically solved.
Yes.
With funding problem. And in the world, because we know that this is a very useful thing, there are still other problems that we are facing. So because we don't know how good they are, we don't know how to maximize.
So if you just look at Hong Kong, Michael, do you feel that we have enough number of implants every year for our patients, for our needed patients?
In Hong Kong, our welfare system is based on a need basis rather than what we call a top-down approach. Okay, so we don't limit actually the needs of our people very much so, as long as you can prove that this is something very useful. So we don't want to waste our money. I know some people will perceive it slightly differently now, but I must say that in the past 30 years we have not changed. And as partly sometimes I make decisions for resources, and you also make decisions for resources, Victor.
Yeah.
You would also like to have it on a need basis. When people really need it, we have to promote it and try to get it. The problems in running cochlear implant program universally today is still almost the same, but I must say that in the 1990s, these are what we are facing. We don't have enough professionals. We have lots of professionals behind the story, audiologists, speech and language pathologists. We don't have even the materials to do it. We have to do research. We have to invent our own tools. We don't know how to maximize the outcome. And there are also lack of educational facilities. So you don't know where to place this child after they are implanted. So especially in China, they have vocational training school for deaf people, but they don't have proper training channels. Okay, so we have to start building everything from together. In Hong Kong, we have 4 deaf schools. So in '93, I don't know why I was clever at that time. So I actually approached the deaf school at the first go before I do my first child. So we have perfect support from deaf school. And globally, there are a lot of resistance from the deaf community and deaf schools because they don't trust physicians. They don't want to send their kids to a surgeon to be operated on a device which doesn't seem to be useful and threaten their survival. But in Hong Kong, we have very good support. And subsequently, we also go and support the whole of Asia and the world about how we run these systems. And today we're very proud because we don't have really any deaf school. We have only integrated normal schools for our child. And we are probably the only place in the whole world who are doing this for the last 30 years. So I need to go back to the story of Bingyu. And Victor, you'll be interested to see what happens. There's no resources, so what can we do?
I can imagine.
So this is Bingyu story.
It's just amazing how children do.
So the mom is doing her own training because there's no people who are qualified to do training. And also we also don't know a lot of things because the recommendation from the only places with some children who are implanted apart from Hong Kong is Australia. And they said you should not implant somebody who is older than 6. So Bingyu is around 6 at the time of implant, 4 to 5, close to 6. And also you should not implant somebody who have no experience of using hearing aids, and the performance or the outcome will not be good. So, and also you should not implant someone without a proper training channel. So we are violating a lot of principles by operating on her. We along the same time, actually, you can see that I must thank to Lady Bao, Dr. Bao now. You can see the lady who are wearing white glasses. You know also Ms. Bao, she is the head mistress of the Hong Kong School for the Deaf at that time. And we started building the infrastructure in China from zero. Basically, we travel all around China and build up integrated teaching programs. So we train deaf educators, We train school teachers. We build schools and university-affiliated programs, starting from that time. So my weekend are all spent on these perspectives, and sometimes I do have to do the weekdays apart from the very busy work that hospital authority is impinging on its first 5 years, 10 years initiative. So we all work very hard, and in the Prince of Wales Hospital we are building our team. So from 1993 to 2020, we built a very comprehensive team approach with research emphasis. So we have developed a lot of tools which become the examples of most Chinese tools that are present today. We do cohort studies. We do some, as you said, spectral study, that we increase the number of channels that they would be able to stimulate. And we also try to improve the hardware design and develop future approaches for some of the unique problems that we are facing.
I can see your wonderful speech and hearing team. They are very important, aren't
yes,
they?
Yes.
Because surgery is just the start of everything, and they are the ones who train up the, the children and the adults.
Victor, you speak Cantonese.
Yes,
obviously.
I do. Yeah.
And because you study in Hong Kong.
Yes.
So for someone who has never speak Cantonese, how good you think they can speak Cantonese?
I think it's very difficult. Too many tones.
Can you give an example apart from, say, even our teachers? Remember Father Naylor, he's one of the best teachers we have. Both of us learned, but he couldn't speak good Cantonese.
Yeah.
A late Father Naylor tried to learn Cantonese for years, but he couldn't speak good Cantonese. It's so difficult for someone to learn Chinese. Why?
Sure. Because too many tones.
Yes,
the tones are variable. Tiny bit of variable makes a big change. Like soup is tong, but you warp it a little bit, it becomes tong. Tong, and then it becomes sugar. It carries very different meanings.
You know, tongues to us is natural.
Sure.
But to a non-native speaker, it's like listening to music. There's a lot of information in it. So we go to the slides, and you can see that I'm showing the examples of, say, Cantonese tongues. So this is 要推介你係咪一個導遊? Okay, so if you know we're asking this question, or else the same like exactly the same phonetics but very different meaning. 你係咪一個導遊? So to the non-native speakers or even a young child, these are very difficult things for them to differentiate. Okay, because they have got same phonetic segmental structure, but the tones, just the tones, are different. And these tones are basically pitch patterns. And Chinese, including Cantonese, is the earliest language that we need to study for these lexical tones. And they're even being studied beforehand. So for us, our first task is actually to design materials. So these materials are designed so that we try to ask our implantees whether they can differentiate tones. So these are choices that we try to ask them to make. And also we build in words, the different tones into words and sentences recognition, so that we could have scores and design the scores. So this is a huge lot of tasks. So for this tone acquisition, we expand further somehow into how we could break down the speech components and improve on the current strategy so that the implant can maximize their ability to detect sounds. So we also designed speech rehabilitation programs in Hong Kong. So I'm showing you the materials that we started using in 1990. Still today is the gold standard for training.
茶。
茶。
係啦，襪。
襪着乜咯？
喺邊度啊？
冇襪啊！
你冇襪，我係冇着襪。我今日冇着襪啊，咁啊？
我今日有隻仔。
係啊，
眼咯。
我話係唔係？係噃，跟住我話洗完手先食飯。係喎，叻喎！好啦，跟住我話星期日去旅行好唔好？星期日好唔好？係咪啊？好啦，跟住我話哥哥中意食魚。
哥哥食魚。係啊。
Wow, that's wonderful to watch, but they are prolonged, tedious sessions.
Yes, so really we're talking about speech rehabilitation is a major part of the entire program. Our research have shown that actually this is a slightly complex chart, but it all depends on when you are implanting them. Okay, so for this chart, if you look at the age of implant, so when we are implanting, say, after the age of 6, which is about 7, the ability to recognize work become limited because they plateau off at about 50% of word recognition. But if we implant them very young, say younger than age of 2, you can see that all of them will almost reach 100% at the age after 1 year of implant. For instance, if you implant them at 18 months, they will reach their plateau. It's like close to a normal child by the age of 2.5. So really, the most important factor over here for a successful cochlear implantation is when we are implanting them.
Exactly. Michael, we have a wonderful system within the Hospital Authority of neonatal screening, as you know well.
Yes.
So we screen them out, and then we confirm their deafness, and then we try and put aids in before 6 months. But of course, your candidates, even with aiding, they do not respond well, and we should be able to get them by 8 or 9 months and send them to you.
Exactly. So Victor, remember how this is brought into place. That was the same Nanjing trip that we are going to.
DPOE.
So it was 1994.
Yeah.
We learned about a device called DPOE in 94.
That's right.
And then we also begin to know that we have to implant a child very early.
Yes.
Nobody else in the world are talking about that at that time. So we actually find out that someone in China spent a lot of money in buying a system. And this is the only system available in Asia. So that's why we are traveling all the way to look at the system. And it was so interesting because looking back, we will never know that they're rich enough to buy the system which they don't understand how it works.
That's
and
right.
Only 2 of us know that eventually it became the gold standard of screening.
It was so amazing. I mean, it tested all the frequencies right across the spectrum.
Yes. So, and then after that, we begin to do some experiment. Actually, we acquire a system. We begin to do some experiment in our neonatal unit, do some screening. And Victor has helped us a lot on this screening, high-risk screening program that was in the mid-90s. And we have published some of those results and subsequently convinced the hospital authorities to set up a task force and become later the neonatal screening program. So Hong Kong is really one of the pioneers in this respect. I must be very proud.
Our pediatricians really do a great job in this, I have to say.
The result I'll summarize actually. For word recognition, basically the age of 6 or 7 is actually the limit. And if you could implant them young enough, they will be able to actually hold good listening. Bingyu is about 5 or 6 at the time of implant, so you know that she will acquire good recognition. If you want to get good tones, this is a slightly different story. So if we plot the chart of good tones, you can see that this is also a very complex task. But you can see that the good result only will obtain at a very young age of 3 or before 3, okay? So if you want to operate on them, say before the age of 2, they get very good accuracies, 80% by 1 year that I was told. But if they're older than 4, they could not achieve well, even after 5 years of training. So In fact, this is a lot of differences in acquiring those. So I summarize in this chart. So for tongue production, somebody with good tongue production, you've got to operate at the age of 3 or before 3. And if you operate on them, just by the age of 6, they could get good word recognition, but they can't differentiate tones, so they don't get the real appreciation of pitch. So these are all because of our brain, because our brain will no longer be plastic enough to do the job. So I'm showing you another chart. So we're falling behind stories of the 90s where we know those things. And then we're doing more and more implants now. Victor, do you guess why we're doing more implants now?
You're doing the other side, aren't you?
Yes, exactly.
Yeah,
so in Hong Kong, we are also very gratified. We are the first Asian country to offer bilateral free cochlear implants to those who need it. And more recently, we begin to have our single-sided deafness research.
Yes.
And these are the 2 reasons that we're expanding gradually the criteria for cochlear implant. And worldwide, there are also other stories of infiltrating into different developed countries. The sort of like much easier to get government funding. In China, they get 1 implant funded by the government all around China. So you have about 1/3 of those who are globally implanted or Chinese now.
Michael, I'll come back to speech scores and age of implantation. If you had a choice, what would be your optimal age of implantation for a child with deafness that we have identified? Let's say we send it to you at 8 months.
We talk about the scientific point of view and the clinical point of view.
Sure.
Okay, the scientific point of view is any age where we diagnose significant, severe, or more than severe deafness, then we should implant.
I think if we can get
any
it
age
by 4 or 5 months, is pretty good for Hong Kong.
Yeah, clinical age we have to decide on other factors like how sure we are assessing our child, what are the accessibility of the healthcare services before and after. So the problem of anesthetics to a young child, because blood loss is minimum for the surgery, but still significant if they're newborn. Okay, so we can't operate on newborn. But
for the ENT surgeons, any technical difficulties operating on an infant?
My answer is they have thinner skin, so you have to be more careful. I don't do fast surgery. We do very careful, meticulous surgery, and we don't also very precise surgery. We have better tools now, so we might use some of the better tools now for some of the really difficult young patients. And you see some of the progress over there. But let me go back to Kyle, remember?
Sure.
Victor, Kyle is the example. Kyle, this is Kyle now. Kyle is in Thailand because his family has got some background. Kyle is playing baseball. Wow. You see how he's hitting those, okay? He has inner ear problem as well, because most child who are born with bilateral deafness will have vestibular problems. So, but he's growing out of his vestibular problem, you can see. So he's hitting it very well. Kyle's mom, Robin, her smile, very different. Same hug, but very different smile. Yeah. So you see the true happiness in her face. Family picture. Yeah. She says she's very determined to get Kyle to Olympics. No wonder, I'm sure, because Robin is listening to my talk here. I'm sure Kyle will one day go to Olympics.
Yes.
But I'm surprised because I'm actually not very surprised, but I'm very surprised when her mom asked me. So she sent me by WhatsApp. We become friends, okay? I know the stories of my patients. I like sometimes to talk to them and know what's happening to them. So, but I don't really need to see them as a patient. So she sent me those, okay? So this is Kyle's test score. In Australia, so he's going to one of these camps, and then he had a formal test. So you can see that at the age of 3, this was May 2019, This is her test score. So her sentence structure score raw score 15, and he scored 15 out of 16, and above average. Then the word structure score is not scoring too well, a little bit less than 3 years old, and expressive vocabulary doing well, high above average, 3 years 7 months, and concepts and following directions 4 years 2 months. So these are more related to cognitive developments. Recalling sentences related to both speech and communication. They all score above his age. But my question is, why Kyle's score is low on the word structure? But I can't really answer, because I think this is with the test, this inability of sometimes this test score to test the real ability, because word structure should be link aligned with recalling word sentences. So this is probably why you are testing the child is not attentive.
Kyle
you
had
don't have a
unilateral implant, is that right?
Bilateral.
Okay.
So in reality, we are looking at a child who was implanted at 9 months. So by the age of 3, his scores is like a 4-year-old.
Oh, right.
Okay,
yeah.
so I'm not sure whether he's now 4. His cognitive scores would be 5 or 6, because Kyle speaks 2 languages the least fluently, and he say hello Christmas to us.
Merry Christmas, everyone.
Welcome,
Happy New Year.
So he's a sportsman. He do a lot of things well in school.
Yeah.
Victor, from that point of view, what next of things that we should go about and learning? Because there's still a lot that we don't know, especially about brain and brain development. So uncovering the brain, there are many tools that we can use now, because we don't need to open the brain to look at how they function now. So these are the sort of like some of the examples of how we look at hearing now. In the past, when we study physiology, remember that our physiology is very simple. The auditory area is a small area for listening, but the auditory area now actually covers the entire brain. I will show you some of our own study examples. So going ahead, Victor, remember you asked me the question. If they don't have a nerve or cochlear, can we do something?
That's right. That's right. Yes. Or a very slim nerve that you are not confident in stimulating, yes. Or completely absent nerve. Is that the end?
Yes.
But I know that you can now stimulate
exactly.
the brainstem.
I have another parallel story about how we started our neuro-otology program. If with time, I can share with you. But cut a long story short.
You did the first one in Hong Kong.
We done the first one in the whole of Asia.
Right.
So in 1999, I remember.
Yes, I also
we are still very young at the time. We have a very young team. So today you will think about that we are very brave. But in fact, we have lots of training and practice before that. So in the year 2009, we have actually 10 years history of knowing how to do auditory brainstem implant. And then we also do things differently. So we work with the neurosurgeon actually. At that time, we have a young neurosurgeon, Dr. H.T. Wong, and he just joined our team with Dr. Joseph Lam, who was our previous neurosurgeon, and they're in transition to each other. So we talk about, shall we start doing brainstem implant in young child? So at that time, the only place that has done some brainstem implant in the whole world is in Italy.
Yeah.
They started doing it in 1995 and begin to show some results. And then in the beginning, you'll see that people are very skeptical about these things. So we flew all the way to Verona. I spent almost like 6 months in Italy. So around that period of time, when we are thinking about sort of like how we should start the program, and actually come about an idea that we can also do minimally invasive approach to this. So I'm showing you how we could do and insert an implant into the brainstem. So this is called auditory brainstem implant. And basically we have an incision, at the back of the ear, not bigger than those we are using for cochlear implant. We try to locate the brainstem from over there. Okay, so small straight line incision. So we open up. So this child, we have a cochlear implant first, but this failed to stimulate because there's no real nerve elements for the stimulation. So the cochlear implant fails. So we open up the skull. So this is called a retrosigmoid or suboccipital approach. This is more correctly a retrosigmoid approach. So this is the cerebellum we approach, and we go about and approach the brainstem. Okay, brainstem is the holy grail for a neurosurgeon as well. It's a very, very important structure, we know, and we insert the implant in. So seems to be a very comfortable, easy procedure. But Victor, today we are still the only team in the whole world who are using this incision. Everybody else is making a big craniotomy for this. So I was talking to a group of international surgeons last week on another webinar, and they're still very surprised that we've been doing that for now more than 30 consecutive cases.
Yes.
So this technique is actually a good technique. So we have very few complications. We have some scalp hematoma, some leak of the CSF. But Victor, I know your question is that do they work? So fortunately, we have only 2 non-users. We still post the best result globally. But my question is that how much this implant can deliver if to stimulate the brain directly. So we do this study, which we spent 10 years in following up these kids and eventually published 2 years ago. So we have this cochlear implant line to compare. The top line, the gray line, is our cochlear implantees, and the lower line are individual patients. So you can see that some of them are achieving very much like our cochlear implantees, but most of them has a delay of 1 to 2 years after implantation. So really, the brain takes some time to formulate the entire pathway, and many of them they are not born with the nucleus to receive the sound, and they have to reformat everything. So this is one of the examples that we are showing we can actually interfere with the brain development with a stimulator in a brain device. So going back to the story of tones, and which is more dramatic, we have mixed results, but they can identify tones and they can appreciate tones, and many of them eventually integrated and have performance very much like our cochlear implantees in the long term. So I'm giving you a story of one of our early child, very brave child and very brave parents, and we implanted him at the age of 2, which is really a young age. Remember our neonatal screening program, we screen him young.
Yes.
We operate on him on cochlear implant young and find that the cochlear implant failed, and then do an brainstem implant. He recently has an ABI fail, and we re-implanted him, but he has got this good result. So his results, the pink line is his result. So he could get tone identification 1 year after surgery at 100%. So when we try to compare his results with other kids who are not performing well, Victor, do you know our findings? The same thing happened, which is age, because we implant him young enough to do it.
They do a bit better.
You
a lot
see,
better, probably,
yes. So you see, he about at the age of 4 on this video.
你好，你叫咩名啊？
3歲。
係啊，你幾多歲啊？
3歲。
係啊，3歲咩
？4歲啦。
4歲啦，係咯，我記得唔係。
4歲。
4歲。
係啊，你頭先係咪翻學啊？嚇？你頭先係咪翻學啊？
搭巴士。
搭巴士嚟啊？咁你一陣間去邊啊？你屋企喺邊度啊？你住喺邊啊？
喺紅磡。
紅磡啊？紅磡邊度啊？
嘉圍村。
嚇？
嘉圍村。
嘉圍村啊？哦，今日邊個同你嚟啊？
拜拜。
好啦。
So basically,
it's amazing. It's amazing
amazing
how the pediatric brain can work.
Yes, there are a lot of other stories about this, and I hope I can share with you.
Sure.
But basically, one of my research students looked into how we perceive tones and the Chinese language on these functional fMRI images. So for the fMRI picture, you basically look at the brain at 3 different dimensions, the 3 different cuts. And when we are presenting tone identification to them, their whole brain will ignite it, including areas which are not known to be related to language. So the major area, of course, is the auditory cortex and the premotor area, which we find out now is very important for understanding speech and language. And we also find out that the occipital lobe, which are supposed to be territory of our friendly ophthalmologists, is now our territory. So we probably have to do more tests and eventually research to know more about this. Our students are also very clever. They start to develop AI programs for screening children's speech problems. They won many awards. We are also looking into the next phase of surgical development. Victor knows that I was very enthusiastic about using the tiny endoscope for the ear, and I sometimes do some things impossible. So this is one of the impossible tasks, is we use the endoscope to do a cochlear implant. But this patient has a different story because he has a vestibular schwannoma. So I'm showing you the endoscopic picture of the ear, which we are dissecting from the ear canal and removing the tumor from the ear. So we remove the ossicles because he is totally deaf, and remove the stapes, which is the smallest bone in the human body, and take out the tumor right from there. With a very magnified view of the vestibule. So we drill along now. We are at the superior semicircular canal and the lateral canal, and we try to deliver the tumor underneath from the vestibule on both sides, behind under the facial nerve, with the endoscope. So I was asked actually by my patient, there's lots of bleeding, but actually the whole operation we have about 3 cc of blood.
Yeah, about it looks a lot
because it's a very
like
magnified view.
Looks like the Red Sea under the microscope, endoscope here. Yeah.
So the tumor is coming out eventually. You can see the vestibule afterwards. So we are now trying to start using the endoscope for some real histological and microscopic work. So you can see the vestibule carefully. Then I go and do the cochlear implant through the ear canal. So it's the largest implant we can find to go through the ear canal. So you can see
still through the round window here.
Yes. So we also start to do some robots and robotics in our other initiative. So this is showing you how you can do eye gaze control for robots. It's okay. So let me finish my story with Bingyu now with you, Victor. Bingyu 17 years later is grown up. Well, I went back to visit her mom. That was about 6-7 years ago.
Yes.
So her mom is very clever. She actually used to be a store sales lady, but now she opened a school. So to actually look after deaf kids, and won many awards. Not to make money, but she has a very good size school in Nanjing.
What does she do? Speech training?
Nothing. She learned from herself and become the expert in deaf training and deaf children training. Okay, I must say she is probably the best teachers you can find.
Wonderful.
Many of these approaches she learned it from herself, and she opened that school, very successful in Nanjing, now one of the famous private school apart from the government schools that they have. I show you Bingyu now.
共大学。First of all, I would like to express my heartfelt gratitude not my family members, but have been giving me a lot of care and support. Yet, please allow me to give special thanks to Dr. Wu Xinhuan and the entire medical team and Childsim Hospital. They had been very caring and helpful to me. I have a deep feeling and empathy to the children with hearing loss. I hope that after graduating from university, I would have the opportunity to help and support those children like me, so that I could be a beneficial contribution to the society and give back to the community. Lastly, I wish today's a great success. Thank you.
So I'm still communicating with Bingyu Victor. After working for a cochlear implant company for 2 years, she's now opening out her own initiative work as a marketing manager. And
absolutely heartwarming story.
Of course, I have to thank a lot of people for creating those stories. All the surgeons, audiologists, past and present. Our current chief is Dr. Willis Tong and Professor Iris Audiology Centers Department of ENT, Mr. Terence Wong, whom we are colleagues for more than 30 years.
Yes.
And Professor Kathy Lee, we are also colleagues for 30 years. And today we still have meetings around. We have built, apart from other initiatives, the Institute of Human Communicative Research and the Here Talk Foundation. Victor is also our board director and patient members. Well, story have to end somewhere. My last slide is about happiness. Remember, my title is about happiness.
Yes.
I'm not bringing happiness, or the people who bring happiness. I'm showing you happiness come from actually people himself. Okay. I know this is a difficult time for most people now. Victor, a lot of people are puzzled about what they should do now, present and future. You and my thinking of the world could be slightly different. You and I have different backgrounds. I have a different perception about countries. I have different perception, but my interest is always with people, and I know we can always come out of this. So my life could not be without my family, my wife, who's always stayed young, which is fortunate or unfortunate. Victor knows my wife very well.
Very well.
We fight with each other, but these stories are running parallel in my story. I grow old and we grow old, and we all enjoy our happy life together. And I hope this message will pass along and people will enjoy their life. Thank you very much, Victor.
Thank you, Michael.
Thank you, Michael. We have a question here.
Okay.
Before going into the question, I'd like to share my sentiment. It's a lot of nostalgia here. You really bring back some of the good old memories that we share, especially as a pediatrician who witnessed the beginning of the hearing screening. And initially, we have the skeptical idea about cochlear implant, but now I think this is a very, very good turnout of the whole endeavor of doing hearing screening. I have a question from the audience: is that what is the benefit for bilateral implant over unilateral, and how about the benefit versus the risk issue if we are doing the bilateral ones?
Thank you very much for the question. Actually, we're talking about science and philosophy here. The science is that all of us who are so-called normal are born hearing on both ears. So naturally, everybody is at an advantage of using both ears, because naturally this is an advantage in real life, because if you listen with both ears, you can hear better in a noisy environment. You can hear better directional sounds, because like where the sounds are coming from is important in daily life. And if you can hear only with one ear, you probably lose a lot of these messages, and your brain are not developed as good as those. So when we are implanting bilaterally, we are actually giving back a normal, so-called norm of hearing to the child. And the risks, really, there are not much risk, because under good hands and with good training, most of us are in Hong Kong, I must say. So the surgical risk is minimum. We might have to do re-implantations for some of the implant failures or infections, or we might do something about hematoma. But really, we are not talking about a difficult surgery, a surgery which is 99.9% without problems, and also they can use it for life. And the re-implantation rate is less than 1% now. So, we really have no reasons to reject somebody who's getting back to the norm. But we also have to think about sort of resources and other things an issue. In Hong Kong, we are also very fortunate. We can convince the need-based resource allocation.
Oh, that's very good. Michael, looking at Bing Yuk, who's
Yes.
17 now, 17 years post-implant, there's always been the debate over upgrading the implant and putting in a new one because it's slightly better. There's no need to do that because there's enough signals in there. And if it doesn't get infected,
the actually
it's
external
safe for
process
life.
has been upgraded twice for her. So I was discussing with her implanting her second side. That was about for the last 2-3 years, and she's hesitating because I think it's another major decision because the second side won't be having good results now. Okay, because we know that it's never comparable with something you have been wearing for years. It's been adapting in a part of your life. But I do recommend her to consider. And one way or another, there are also things that we don't know. We have to watch, and we have to tell them our truth and our gut feelings. And they're never a science many a times when we make decision. And this has told myself a lot of sort of like or taught myself a lot of things about life as well, because we never know what is the right decision to make.
Very true.
A follow-up question from the audience. Is bilateral implant the standard now in Hong Kong?
Yes.
Yes.
So we do recommend bilateral implants. Some centers will do what we call sequential, so they will do one implant after another. Some centers will do simultaneous. So I do personally recommend bilateral simultaneous implants.
Okay.
Because the surgery is not that traumatic, and we save up a lot of resources. And also, if you implant them young, you know how good the outcome can be. Some parents eventually they don't choose bilateral, so this is the parent's choice. And also we also begin to think about doing some what we call asymmetrical hearing loss. So children might have a quite good ear on one side and a bad ear on the other side, and our early research have shown that they are also very good candidates, and they can be benefited from cochlear implant, early cochlear implant as well.
Yeah.
One question following your comment about the earliest age to do the implant. This listener like to know what's the average age that those screened out to have a hearing problem in Hong Kong now receive the implant, the average.
Okay, so the average age that we can diagnose through the neonatal hearing screening program is actually less than 6 months.
Yeah.
So we diagnose most of them less than 6 months. There are other resource restraints because we need to do hearing aid trial for them. And so most of them get implanted because our implant criteria is 1 year, 12 months of age. So we recently revised our criteria, which pushed it to 9 months now. So we hope that the majority of them will get implanted at 9 months. But as a matter of fact, most of our children are implanted between the age of 12 months and 24 months. Okay.
I really hope to see it.
Yes.
See the 9-month implantation program.
So I would be very much move forward, or like to move forward with 9 months to 12 months as the recommended age. Yeah.
Victor and Michael, we have more than 200 people zoomed in. We're still calculating the number of
thank you for joining us.
Workstations.
It's very kind.
In HA. So I think we have a record high attendance of your talk, which I enjoyed tremendously, actually. So I like Victor perhaps to thank Michael on our behalf.
I would like to first thank the audience for joining us, and I have to thank Michael for I would have to say heartwarming, sobering, and most enlightening sharing. It's not a formal lecture of any sort, but this sharing is so important for our good friends. Pediatricians are wonderful friends. They are doing a great job And if we can all share all that experience and we all share that knowledge together, we can make our children a lot better, particularly deaf children. Thank you so much, Michael, for coming.
Thank you, Victor.
Professor Tong.